aspects relating to our practice at the moment, as well as some of the mental aspects in the context of COVID-19. We know that the current epidemic is putting many of our health personnel under severe physical strain, but we cannot underestimate the mental and psychological strain which people are experiencing, relating to uncertainties, relating to the increased workload, relating to the fear of being ill. And at the same time, we know that this is all part of the test that we are being given by Allah subhanahu wa ta'ala in this difficult time. And obviously we need to equip ourselves with the tools to be able to pass this test, so that we use the epidemic to bring ourselves closer to Allah subhanahu wa ta'ala, rather than it being a means of taking us further away from Allah subhanahu wa ta'ala. So we make dua that inshallah this program is useful and beneficial for all who are attending. We have got 3 speakers today. Huzaifa, am I right in that we are still sticking to the schedule as advertised? If that is correct, our first speaker is Dr. Farzana Taraja. Farzana, are you with us?
Gee, I am.
Okay. So I'm just going to introduce Farzana. Farzana is a psychiatrist in practice at the moment at the Kusani Berkwanath unit, at the Child, Adolescent and Family unit. She has got extensive experience in psychiatry, having done her training already as a psychiatric registrar through the University of Witwatersrand between 2006 and 2010, and then has worked in various institutes, both in the private and public sector, and has got extensive experience around the management of a variety of psychiatric cases. But of particular interest is that she's got a fellowship in child and adolescent psychiatry, which is currently doing, and inshallah she will be able to give us some insights and anxiety in the time of COVID-19. Please go ahead, Farzana.
Jazakallah, assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah for the opportunity that you've given me to speak to you today. I've chosen the topic anxiety in the time of COVID-19, but I've decided to... Sorry?
Sorry, man. It was a... Please carry on, Farzana. I was trying to switch off my mic. I apologize.
No problem. So, assalamu alaikum again. My name is Farzana Taraja. Jazakallah for the opportunity to talk to you all about anxiety in the time of COVID-19. I've decided today to structure my talk in a very general manner. So you'll see that it's about anxiety in general, and it applies to us as healthcare workers. But I've also structured it so that you as a healthcare worker can identify the features in the patients that you are treating. So life has always been unpredictable, and more so now with the current COVID-19 pandemic. It is normal to experience some level of worry, anxiety, and stress in the face of our current challenges. And it's a normal reaction to feel the need for safety, certainty, predictability, and control. Anxiety is a normal emotion. It alerts us, it prompts us to adapt, but the problem arises when we are overwhelmed by our anxiety. And in this case, it does more harm than good to us. So what is the difference between a normal amount of worrying and an anxiety disorder? When we are normally faced with a challenge, we experience some level of worry, and then once the challenge is resolved, we normally shift back to a more relaxed state of being. But a person with anxiety disorder has incessant worry every day, most of the time for no particular reason. And as a result of this persistent worry, there is a prolonging of the body's stress response. And this has a negative effect on both your mental and your physical health. I'm going to start off by talking about generalized anxiety disorder. So generalized anxiety disorder is characterized by persistent and excessive worry about a number of different things. A person with generalized anxiety disorder may be overly concerned about their health, their family, their work, or their finances, and they may find it difficult to control their worry. An individual with generalized anxiety disorder may worry about actual events, but the worry is in excess of what that stressor warrants. Or they may expect the worst outcome even when there's no apparent reason for their concern. We know that generalized anxiety disorder can begin across the life cycle, but it seems to be that the risk is highest between childhood and middle age. Although the exact cause of generalized anxiety disorder is unknown, there is evidence that biological factors, family background, and life experience, particularly stressful ones, play a role. Generalized anxiety disorder is diagnosed when a person finds it difficult to control worry on more days than not for at least 6 months and has 3 or more of the following symptoms. The patient may describe feeling on edge or a sense of restlessness. They may complain about fatigue. Our patients report impaired concentration, or they may describe that they feel as though their mind goes blank. They may report increased muscle aches or soreness. Patients often describe sleep difficulties. So they might describe problems falling off to sleep, or they might tell you that even when they do fall off to sleep, they wake up at some point of the night or in the very early morning, and then they have difficulty returning to sleep. And some patients might say that even though they know they've had an undisturbed sleep, the sleep is not refreshing. Next, I'd like to talk to you about panic disorders. So panic disorder is diagnosed when a person experiences spontaneous, seemingly out of the blue panic attacks, and they then become preoccupied with the fear of having another panic attack. Panic attacks occur unexpectedly. They begin in early adulthood, but many children may also experience panic-like symptoms. Panic disorders can interfere with daily life significantly. We know of people who miss work because they fear having a panic attack at work, or they avoid situations where they fear they may experience a panic attack and be unable to escape, like a shopping mall or at a family wedding. During the panic attack, there is a rush of intense mental and physical symptoms which the individual experiences as very distressing. So just to recap, in order to diagnose a panic disorder, the panic attacks must be recurrent. So there must be more than one panic attack, and they must be unexpected. So there's no obvious cue or trigger at the time of the panic attack. Some of the clinical features of a panic disorder are racing heartbeat, feeling faint and sweating, or the patient might describe having nausea, chest pain, shortness of breath. As you can see, these physical features can overlap with many medical and other psychiatric diagnoses. They may experience trembling, hot flushes, chills, shaking of limbs, a choking sensation, and dizziness. They may tell you that they experience numbness or a feeling of pins and needles, dry mouth, ringing in their ears, a feeling of dread or a fear of dying, a churning sensation in their stomach, or a feeling that they're not connected with their body. So these symptoms of a panic attack generally last between 5 to 20 minutes. Some people will have 1 to 2 panic attacks in a month, while others may have several attacks in a week. In this slide, I've included some of the techniques one can try when experiencing a panic attack. I will go into management of anxiety disorders in general, but I just thought it might be helpful to mention at this point that if you, as a healthcare worker experiencing a panic attack, do not fight it, stay where you are if possible, breathe slowly and deeply, remind yourself that the attack will pass. Focus on positive and relaxing images and remind yourself that the panic attack is not life-threatening. According to the Diagnostic Diagnostic and Statistical Manual version 5, which is what psychiatrists use to diagnose psychiatric conditions, trauma-related disorders were moved from the anxiety spectrum disorders into their own category. But they have the same features as anxiety spectrum disorders, which is why I've chosen to talk about this today. So under this heading, there's acute stress disorders and post-traumatic stress disorders. Both conditions share the same requirement for exposure to a traumatic event. This exposure might be exposure to death or threatened death, for example, being involved in a severe accident. It might be actual or threatened serious injury, for example, being involved in an armed robbery, or it might be actual or threatened sexual violence. Now, this exposure might be through direct exposure, or if you as the individual have witnessed the trauma, or on learning that a relative or a close friend was exposed to a trauma. And where the DSM-5 differs from the DSM-4 is that they recognize that even healthcare workers or people who have had indirect exposure during the course of their professional duties may be at risk for developing acute stress disorder and post-traumatic stress disorder. So what is the difference between these two conditions? It's essentially the time frame. Acute stress disorder can occur soon after the traumatic event and last for less than a month. Whereas with post-traumatic stress disorder, the symptoms last for more than a month. There's an overlap in terms of the clinical features in both disorders. Patients may describe a decrease in emotional responsiveness. They may describe difficulties with concentration. They may have dissociative amnesia, where they have increasing difficulty remembering details around the traumatic event. They may have illusions. So an illusion is when you have a sensory stimulus, but there's an incorrect perception or you misinterpret the sensory stimulus. For example, you might hear the wind blowing and you might misinterpret it as hearing a baby crying. Patients sometimes report a sense of detachment from their body, their thoughts, and their feelings. So the world might seem unreal, or they might feel that their thoughts do not belong to themselves, or they might describe a sense of emotional numbing, which we describe as depersonalization. They may also describe feelings of detachment from their surroundings, or people, or even objects, where things do not seem real. A lot of our patients describe a feeling of being in a fog, or they might say that sounds appear distorted, either too loud or too soft. And they may report that time seems to either speed up or slow down or even stand still, which we describe as derealization. Now, the difference between acute stress disorder and post-traumatic stress disorder is that in the DSM-5, we've clustered these symptoms for the post-traumatic stress disorder under intrusive symptoms, negative mood symptoms, avoidance symptoms, and hyperarousal symptoms. So next, I'm going to go into an approach to managing anxiety disorders. I'd just like to start by reiterating that anxiety is a normal emotion experienced by everyone at some time, and that the symptoms of anxiety disorders might be psychological, physical, or a mixture of both. So when should we intervene? Intervention is required when symptoms become excessively distressing or disabling, or when there is a decrease in one's quality of life. And this is in the context of the absence of any clear external threat. What I've done is I've summarized the National Institute of Clinical Excellence guidelines for the treatment of anxiety disorders. So according to these guidelines, we need to start with a comprehensive assessment that considers the degree of distress and the functional impairment for that individual. During the course of this comprehensive assessment, we also need to consider the effect of any comorbid mental illness. We know that anxiety disorders are highly comorbid with mood disorders, especially major depressive disorder. We also need to factor in substance misuse. And this may be prescriptive medication, such as the use of sedatives. It could be overusing caffeine, so drinking excessive amounts of coffee, or it could be drugs of abuse. So your stimulants, cannabis, even alcohol. And we also need to factor in the effect of comorbid medical conditions. From the description of the earlier slides, where we went through some of the features of anxiety disorders, we see that many medical conditions have similar physical presentations. So underlying cardiac conditions, patients who have hyperthyroidism may present in a similar way. So we need to also factor this in. And if the patient has been previously treated for an anxiety disorder, we need to look at the past response to treatment. Where there are comorbidities, we need to treat the primary disorder first. Now, in terms of the management of anxiety disorders, psychological therapy should be used as first line where possible. There's good evidence to support the efficacy of some psychological interventions. So this could be cognitive behavioral therapy, it might be supportive therapy, but because psychological interventions are outside the scope of my practice, I've decided to focus more on the pharmacological interventions. The research has shown that pharmacological treatment is also effective for the treatment of anxiety disorders, with most evidence supporting the use of selective serotonin reuptake inhibitors. Now, when deciding to treat anxiety disorders, we must remember to give our patients verbal and written information on the likely benefits and the disadvantages of each mode of treatment. And where the anxiety disorder may be refractory to treatment or quite severe, we might need to consider combination treatment. Selective serotonin reuptake inhibitors, when used to treat generalized anxiety disorders, we initially tend to prescribe it at half the normal starting dose. And this is because there might be an initial worsening of the anxiety symptoms on initiation of treatment. So for example, the normal therapeutic range for citalopram and fluoxetine is 20 to 40 milligrams. So we might initiate treatment at 10 milligrams. The dose is then titrated upward into the normal dosage range. It is very important to explain to patients at the outset that the benefit they will feel from the antidepressant is not immediate. There might be modest benefit in the case of generalized anxiety disorder around 6 weeks, and this benefit tends to continues to increase over time. The other thing that is very important to talk to patients about is optimal duration of treatment. Most of the patients I've seen say that they have not been, that we as clinicians have not explained to them how long they needed to take treatment for. And when you tell them that in the case of GAD, it needs to be for at least 1 year, many patients have reservations about initiating treatment. What is beneficial is to explain to patients that by effectively treating their generalized anxiety disorder, it may prevent them from developing a comorbid major depressive disorder. In terms of the literature review that I did, studies have shown that fluoxetine is probably the most effective SSRI in the treatment of generalized anxiety disorder, and sertraline is probably the most well tolerated. When we use selective serotonin reuptake inhibitors to treat panic disorders, we again start at a lower starting dose, and we do a gradual dose titration as for generalized anxiety disorder. Higher doses of all drugs may be effective when standard dosages fail. So what we mean by that is where the dosage range might be 20 to 40 milligrams for citalopram, for fluoxetine, for example, you might benefit from using a higher dose before switching to another medication. The onset of action may be as long as 6 months, and while the optimal duration of treatment is unknown, some studies have shown that treatment should be continued for at least 8 months. What is concerning is that less than half of our patients are likely to remain well after medication is withdrawn. Selective serotonin reuptake inhibitors can also be used for trauma-related disorders. Again, we use lower starting dosages, and we have found that higher dosages are usually required in order for patients to respond. Again, the response is delayed, so we normally see a response around 8 weeks. And the treatment should be continued for at least 6 months. All patients that are treated with SSRIs should be monitored for akathisia. So akathisia is a common side effect. It's a feeling of restlessness and an inability to sit still. Some patients might experience increased anxiety, especially on the initiation of treatment. And the other concerning side effect that you need to monitor for is for the emergence of suicidal ideation. SSRIs should not be stopped abruptly, as patients with anxiety spectrum disorders are sensitive to discontinuation symptoms. So when you as a clinician and the patient decide that the patient might benefit from trying to discontinue medication, this should be done slowly. So we do a gradual dose reduction as slowly as the patient can tolerate, and we do this over several weeks to months. I've also included a brief note on benzodiazepine disorders, benzodiazepine use in anxiety disorders. So benzodiazepines provide rapid symptomatic relief from acute anxiety states. But the recommendation is that they only be used to treat anxiety that is severe, disabling, or subjecting the individual to extreme distress. And this is because benzodiazepines have the potential to cause physical dependence as well as withdrawal symptoms. This is not to say that there is no role for benzodiazepines. So what we recommend is that if you are going to use benzodiazepines, you should use them at the lowest effective dose and for the shortest period of time, a maximum of 4 weeks. And you must use them with caution in patients who have a history of substance misuse. The National Institute for Clinical Excellence recommends that benzodiazepines should not be used in the treatment of panic disorder because it rapidly relieves the symptoms, and so patients then do not engage in effective forms of psychotherapy, which is quite effective for the management of panic disorders. Some studies advocate that you might use benzodiazepine initially until the antidepressant becomes effective and then gradually withdraw it. Also, in terms of SSRI medication, some studies have shown that combination, the use of pharmacotherapy and psychotherapy is beneficial. So where the patient might have severe anxiety symptoms, you might initiate the use of a SSRI so that the patient responds better and can engage better in the therapeutic space. And thank you. Are there any questions?
So we're going to open the floor for some questions. I don't know if people have put any questions on the chat, so you're welcome to put some questions on the chat. Otherwise, if you want to pipe up and ask some questions, I'm sure Farzana will be willing to answer that. Thank you very much for that, Farzana. So let's give people a minute or two. We've still got some time. I think we're ahead of schedule, so we should be able to take a few questions. I think while people are thinking, Farzana, obviously, during the time of COVID-19, one of the issues that we have is anxiety related to being in hospital. And many patients don't want to go to hospital because of the lack of support that they perceive they will be able to get from their families and so forth and so on. Obviously, it means we need to think of novel and different ways to allow them to contact their families, including electronically and so forth and so on. Just comment on that anxiety that people have related to being in hospital.
So the anxiety is well-founded, and a lot of patients are actually avoiding going into hospital for other procedures because they're worried about COVID. So in a case like that, if the patient requires urgent treatment, so for example, a surgical procedure, and they are hesitant to be admitted to hospital, then I would advise that the family might consider speaking to their general practitioner about maybe prescribing a low dose of a benzodiazepine to help them with the anxiety. But for me, whenever there's a situation, you must look at the risk versus the benefits. And for me, pharmacotherapy, the risk is low. I mean, and the benefits are quite high because it's an effective form of therapy. So maybe a few sessions with an appropriate psychologist to prepare the patient so that they understand that the hospital, the healthcare workers in the hospital are going to take all necessary precautions to avoid them getting COVID. And then I think the other beneficial thing is that as if you're a medical practitioner and your patient happens to share the same faith, you can also use that angle in terms of reassuring your patients.
Okay, Jazakallah for that. We've got two other questions that have come through on the chat. The one is from Bibi Karolia. She would like to know, I mean, the question is not completely clear. What would you recommend for a patient with chronic generalized anxiety disorder who has been on meds? I'm assuming that's a patient who has already been on sort of a SSRI or something and then has a worsening out. The question is not completely clear.
Okay, so the recommendation is that you start with an SSRI. And if that doesn't work, you can switch to another SSRI or you can use another antidepressant. So there is evidence also for the use of a selective serotonin noradrenaline reuptake, SNRI, like venlafaxine, duloxetine. So there are other avenues of medication that can be explored. And so I would recommend that you try another medication because not all, and you've got to try it for an adequate duration of time. I think the other thing I've noticed in clinical practice is that a lot of our patients don't understand that the antidepressants don't work immediately. So they want this feeling of anxiety to just dissipate immediately. So if you do appropriate psychoeducation and tell them that they need to hang in there for at least 4 weeks before they feel some improvement in anxiety symptoms, and that it's going to require a long duration of treatment, then they might actually respond better because the psychoeducation is also containing for them.
Okay. And then Firoza Arabi says, Jazakallah for this. Can you comment on the acute anxiolytics for use in patients with or without COVID? So I think you did mention something about the use of benzodiazepines in your talk. Maybe you can just talk about that a bit more.
So I think that because we know, although the SSRIs are first line, we do know that the onset of action is a delayed onset of action. So in a patient with or without COVID, if they are having severe anxiety symptoms that's impairing their functioning, then I would recommend using it. But you must have document your target symptoms so that you're always reminded to monitor those target symptoms. So that if the individual reports that those symptoms have resolved, then you can do a gradual reduction in the benzodiazepine and then a gradual withdrawal as well, so that you don't end up with the situation where the patient in the long term becomes tolerant to the medication or dependent on it.
Okay, and then Tasmia Ibrahim has asked, teens going back to school after lockdown, I have noticed to be experiencing severe generalized anxiety disorder. Parents are reluctant to medicate. Psychotherapy is sometimes not sufficient. What types of medical intervention would you recommend to these parents?
So if the parents are reluctant to medicate the child and psychotherapy is not sufficient, it might be beneficial then to work with the child one-on-one. It depends. I mean, if it's a teenager, you can engage with them quite well. I'm not sure why the psychotherapy is not sufficient because psychotherapeutic interventions, the literature has shown, are quite useful. So it could be that maybe there's a mismatch between the individual and the selection of the intervention. So not all interventions work for all people. There's also a lot of there's a wealth of online resources available. So you can even do online cognitive behavioral therapy, which is quite effective for generalized anxiety disorder. And then in terms of other medical interventions, So I focus my talk mainly on selective serotonin reuptake inhibitors and benzodiazepines. But for symptomatic relief, you can use things like beta blockers if the individual is having palpitations. But always, it's especially with teenagers, you have to look at the risks of the pharmacotherapy versus the benefit of instituting treatment. So, and also with the teens going back to school, to be honest with you, my experience has been that it's more the parents who are anxious. So it's more about allaying the parents' fears. And the best thing to do in that case is to provide as much information as possible. So going through statistics in terms of overseas countries where children have returned to school, the rates of COVID in those schools, whether they've seen an increase. The thing is that it keeps changing. Like we recommend to parents that under fives are not really carriers, and then the next week we tell parents, well, actually, recent data suggests that the under fives are carriers. So it's also important to explain to parents that we as healthcare workers are also learning as more evidence becomes available, and that whatever information we share with them is the best available knowledge that we have at that time, subject to change. So if we reassure the parents, then that might also contain the child as well, because often anxiety is a learned behavior. Children pick up on their parents' anxiety as well, and children themselves tend to be quite resilient in my experience.
And certainly, I think the homes can be anxious for a variety of reasons, which are unrelated to the child's risk, including financial stress and other things. And often, a lot of that will transfer onto the entire family in terms of the amount of anxiety that they're exposed to at home.
Definitely. So anxiety can be a learned behavior. Well, if for example, and the thing is, we parents often talk without being cognizant that our children are listening. And so we ourselves are struggling with COVID anxiety. And then over the supper table, we talk about another mayat that we've heard about, or somebody who's on a ventilator in hospital, and the children pick up on our anxiety. So even though we know that anxiety disorders do have a biological basis and you can inherit it, it's difficult in studies to separate which children definitely, unless you're going to do gene studies on them, it's definitely a biological basis, or which children actually it's a learned behavior because their caregiver was more likely to be anxious in a situation.
Okay, is it okay? Just two more questions, Farzana, is that okay?
That's fine, that's perfect. Marv, I think I rushed a bit, and that's why my talk was shorter than expected.
I think this is very valuable what we're getting here. So the question is from Rehana. She says, Assalamu alaikum. Is it at all possible for patients taking SSRIs for over 5 to 10 years to be weaned off or prescribed a lower dosage, or do SSRIs taken for this long period need to be taken lifelong?
So Rehana, the truth is that you have to individualize for each patient. So if the person has been on medication for 5 to 10 years, I would say, and they want to come off medication, do a gradual dose reduction. So if they're on 40 milligrams of citalopram, then you can take 1.5 tablets to drop it to 30 and see them in a month's time and see how they are feeling. Whenever I attempt a dose reduction, I tell the patient, don't look at just going off the medication. You want what's best for yourself, and what we want is to prevent a relapse. So if you notice that with each dose reduction, there's been a change and you're feeling worse than before, you need to let me know. And some patients, yes, we can bring them down and they can go off medications. And some patients might tell you that at 20 milligrams, when I drop it to 10, they notice that they were not coping on the 10 and we go back onto 20 milligrams. So you can challenge them. But whenever I try to do a dose reduction, I make sure that the patient has been stable. So even though you've been on SSRIs for the 5 to 10 years, what has been happening in those 5 to 10 years? Is that patient still having residual anxiety symptoms? In which case, it wouldn't be wise to start lowering the dose. What you want to do is to maintain them on the lowest effective dose and according to the guidelines for the recommended period of time. And as you can see, for anxiety disorders, it's not 1 or 2 months. You're looking at up to a year for generalized anxiety disorder. So if they've been stable, then yes, try to taper the dose, do a gradual reduction, and then you can see. The thing is that when patients have been taking the medication for so long, and then you do a dose reduction and they're struggling, then they tell me, yes, but now I'm dependent on the medication. And I often explain to them, when your relative has diabetes mellitus and they try to decrease the medication and their blood sugar levels increase, does that mean that they've become dependent on their oral hypoglycemics? They haven't. It's because that dose that they were taking was sufficient to control their blood sugar level. And when they attempted to take a lower dose, it wasn't sufficient to help the pancreas do what it needs to do. In the same way, the brain is another organ in the body. And we tend, because of the way we've been socialized, we tend to expect more of the brain. Like when you have anxiety, a lot of us with a Muslim background will say, well, if you just increase your zikr and you just try to read more Quran and you just connect more on the musalla, then your anxiety will go away. All those things, our faith does help us. But when you have moderate to severe symptoms, you need the extra help. And whether that's in the form of psychotherapy or in the form of pharmacology, then you should make use of it because Allah has allowed us. It's not haram. And then if it means that when you've tried to reduce it and you are stuck at a certain dosage, it doesn't mean that you become dependent on the medication. It means that your neural pathways require that dose in order to function effectively. So it's all about educating the patient and making them understand that. I think we fixated on this idea of not being on any medication. I had a patient yesterday and I told her, we'll try to reduce your medication, but I can't promise you you'll be off medication. But I will promise you that I will look for the lowest effective dose on which I can maintain you. And she was reassured by that.
Jazakallah. So just a final question from Bongani Malachle. Doc, my question is not related to COVID-19. I'm seeing a client who was prescribed Accutane for skin treatment. She started experiencing severe anxiety symptoms, that is panic attacks, fears, speech was affected, tiredness, and lately has been complaining about psychosomatic pains, including headache and back pain. They later prescribed Resnia for her and the symptoms worsened. What would you recommend she takes to deal with the symptoms?
See, in this case, the anxiety is caused by the medication. So if you remember, Bongani, earlier in the talk, I said that anxiety disorders can be related to the stressor, and then some features of anxiety are related to medication, either prescribed medication or drugs of abuse. And so you can start on an antidepressant to manage the anxiety symptoms. And maybe the reason why her symptoms worsened could also be the dose at which medication was initiated. So in her case, I think you would have to go with pharmacotherapy. I still prefer SSRIs because the literature says that they are safe to use. And because sertraline is well tolerated, so if you remember my earlier slide, in terms of efficacy, fluoxetine is better, but in terms of tolerability, sertraline is very well tolerated. And the dosage range, so an effective dose of sertraline is 200 milligrams, but you start at like a small dose of 25 milligrams and you gradually increase it. Then hopefully she will respond to that. But bearing in mind that this is related to her treatment with Roaccutane. So once she stops the treatment, you would want to monitor to see whether the symptoms are still there, whether it's coincidental that you just develop the panic symptoms or whether it is related to the medication. So what I often do when I'm making notes is I write down target symptoms. I write down possible predisposing, perpetuating, precipitating factors so that I can monitor those. And then I monitor response to treatment. And then I know when it's time to actually start tapering and stopping medication. And in terms of using antipsychotics for the management of anxiety disorders, there is a role. So it's not first line. You would start with any antidepressant. You would go SSRI, then a SNRI. You can even use a tricyclic. You can augment with an antipsychotic. Some doctors, if the patient is very uncontained, they might opt to use a second-generation antipsychotic to contain the patient until the antidepressant kicks in. So we often use risperidone, quetiapine, even olanzapine can be used in the management of anxiety disorders. But bearing in mind that you're using it in the initial phase because maybe you don't want to use a benzodiazepine in that particular patient, and you would have to get the buy-in from the patient, because if you have an anxious patient and they go and Google quetiapine and they see it's an antipsychotic, they get quite distressed because they think that you haven't told them that you think that they're psychotic. So I often explain to them, this is an antipsychotic. It is not indicated for the anxiety, but we do use it off-label, or we do use it in the initial stages to contain you. And my aim is, once your antidepressant becomes effective, when you start responding, I will taper and stop the antipsychotic.
Jazakallah, thank you so much, Farzana. I think that was really quite a lot of detail on multiple areas of practice, and this can really be a difficult group of people to treat. And as you mentioned, the complexities are significant. Often, obviously, they're hypervigilant about side effects because of the anxiety already, and those side effects continue to get worse, no matter or sometimes worsen the anxiety. So you have to be really careful about how you educate the patient, as you pointed out numerous times. So Jazakallah, thank you for that, Farzana, and thank you so much for the insights you've given us. And we move on, inshallah, now to the next speaker. The next speaker is Hanifa Ibrahim. Hanifa is going to talk to us about emotional wellness and caring for the mental health of healthcare workers during COVID-19. And let me tell you a little bit about Hanifa. Hanifa is a counseling psychologist in private practice in Johannesburg for the last 13 years. She has worked extensively within the employee wellness sector. This has allowed her to facilitate processes as a trainer and as a therapist in the wellness field. Hanifa's experience ranges from facilitating group trainings in resilience, stress management, managing work-life balance and change management, as well as facilitating group processes, including debriefing. She has a special interest in trauma and the impact of trauma, and she has trained in various psychological approaches that address the impact of trauma. Obviously, she's going to address some of the issues around COVID-19. I can tell you that Hanifa can also psych you up substantially if you're planning to do the Comrades Marathon. So Hanifa, welcome.
Thank you so much. I'm just going to share my screen with you. You couldn't help yourself, hey, Shoaib, with the Comrades, but...
Yeah, okay. No, you almost psyched me out there, Anita.
Okay. I hope that you all can see. Okay, great. So, Assalamu alaikum, and thank you for this humble opportunity to share some of my thoughts and my knowledge with you. And thanks to our previous speaker, she really summed up anxiety quite nicely. But I'd like for us now to take the opportunity to hopefully take off our healthcare workers' hat and just kind of put on the hat of being a human being, being a mother, being a father, being a sister and a brother, and really just take an opportunity to reflect on where we at right now in terms of this pandemic. Hopefully by the end of this presentation, you would be able to take away at least one tool that will help you navigate psychologically during this pandemic. Okay, so I'd like you to just take a seat, take a moment and just sit in your chairs. And I'd like you to imagine that you are a ship in the harbor and there's an imminent storm and it's brewing. And you begin to see the clouds darkening. You see the flash of the lightning. You feel the raging undercurrent. You hear the rolling thunder. You feel the swaying back and forth as the wind howls. So when ships are in the harbor and a storm is imminent, these ships are anchored to prevent them from being swept away. Now, anchors don't take away the storm, but they can hold us steady. So within the context of COVID is this big storm. It was something that was unexpected, And we prepared somehow for the safety aspect in terms of PPE. In the initial phases, we were looking at hospital beds and preparing for the uncertainty around that and creating field hospitals. But psychologically, I'd like you to think about what anchors have you put in place to ground you, to prevent you from burning out or suffering from post-traumatic stress. And have you invested in your mental health? And that for me is really the important question that we as mental health care workers need to be asking ourselves. So we know that COVID-19 has shattered our assumptions about the world. It has impacted on our sense of security. It has triggered fear and anxiety. And our sympathetic nervous systems, that these are the fear centers in our brains, have been triggered. So there's extreme pressure on our internal resources. And some are saying that the world is grieving. Some are calling it a global depression. And it is marked by a sense of loss. So all of us are feeling the sense of loss, the loss of what was, a loss of a sense of normality, the loss of connectedness, and connectedness to our families, connectedness to our patients, connectedness to ourselves, and just a feeling of isolation.
Assalamu alaikum, Hanifa. Sorry, maaf to trouble. It's Huzaifa here. I believe that you're sharing the window and not the desktops. The slides are not changing on our side.
Okay. I'm going to go back. Sorry about that. Huzaifa, you didn't teach me a proper tutorial. Hey? Okay.
It's maaf.
It's my fault. Okay. Let me try now again. It's not giving me that. So let me just try again. Sorry, Huzaifa. Let me go out and back again, okay?
Jay, I think just stop sharing and then start resharing again.
Okay, let's try again. Open desktop. Okay, so that's my technical difficulties. Okay, there we go. Sorry, guys.
I think start the presentation. Yeah, there we go.
Yes, perfect.
Yeah, I'm getting better at this. Okay, so as I was saying, that some are saying that it's a global depression, which is marked by a sense of extreme loss. So in light of the pandemic or the current pandemic, mental health workers are not protected from these feelings and emotions, and feelings of being afraid, anxious, stressed, overwhelmed are completely normal. It would be a normal response to an abnormal situation. None of us have experienced something like this in our lives, so we would expect you to feel all of this. Okay, so I'd like to share some of the research around some of the challenges that we as healthcare workers are facing. So there was a study that was conducted already in 2019 regarding the burnout rates pre-COVID amongst healthcare workers. And this study showed that there were already 84% rates of burnout amongst 170 registrars in clinical medicine. And another study done in 2015 looked at anesthesists, and we know they're very vulnerable to contracting diseases because of the nature of their work. It shows that about 40% in public and around 20% in private have high levels of emotional exhaustion and burnout. Okay. So not only are we faced with kind of the normal feelings that everybody else feels, but there are specific challenges for the healthcare worker. And the one challenge that we're seeing all the time is that, or that makes it really complicated, is that every time they go to work, they have this traumatic exposure. So they're constantly concerned about their safety. Will they be infected? Will they give this infection to their loved ones? And in certain sectors, like public sectors, there is insufficient PPE. So that feeling is exacerbated. And the fear of losing their lives is really real for most healthcare workers. And one thing that's really, we saw in studies, specifically within the Italian healthcare workers in Italy, was the concept of moral injury, where they had to make tough decisions around who was going to get a bed, who was going to get a ventilator. Is that person young? Is the risk factors more? Are they older? And they had to make tough decisions that really sit with them, and they have to, that they ruminate about. And we currently seeing, I did a debriefing yesterday with some healthcare workers, and they're already questioning, did I do more? Could I do more? Did I do enough? Was there more, was there other resources that I could have drawn on? And other general workplace stresses, if your colleagues are getting sick, if you're, you're feeling unsafe, you're wearing PPE, your workload has increased. And I see a lot of this with individuals in the private sector who are on multiple chats and multiple groups, and they're working 24/7 because they want to see that their patients get better. And COVID patients are not as easy patients. They're difficult. So there's constant complications, and you need to be available. And that ability to switch off is just not there. And then the second shift, home stress, the normal second shift, where we need to deal with kids, and kids that are with us constantly, so they're not even going to school. So, and then we need to deal with teaching them at home and becoming teachers in the home environment and ensuring that they're taken care of when we're at work. So the challenges are compounded from a psychological perspective, and we need to acknowledge that it's not easy for healthcare workers right now. So we know that there are other risk factors for adverse psychological outcomes, and by no means do we want to pathologize this, because we do know that it's COVID's unknown, our body's responding, and some of it is just normal. But there are some risk factors based on the research. So people who are in direct contact with COVID patients will definitely feel more overwhelmed. Nurses, we know that there's immense stress and pressure put on nurses at the moment. They're there for patients 24/7. They're there to take care of them, but they also become family members. They become bearers of bad news. They need to be there for the patients in multiple ways, and it's really, really overwhelming for them. We know people with less experience or their low educational levels struggle in that spaces. And also part-time workers, they don't always have a sense of belonging if they're in a hospital setting and they're in and out, and they do struggle in those spaces. The workplace itself, so if you have an absence of support in the workplace, or there's inadequate training, or individuals are feeling like there's not enough, or there's no confidence in infection control, or if there's just no compensation for staff. So if I'm not getting overtime, if I'm not getting, I'm not feeling like I'm being rewarded in some way, then it does impact on levels of motivation. And generally the social stigma around being infected yourself. So initially, especially in hospitals, individuals who had gotten infected, when they came back, they felt ostracized or they felt disconnected because individuals were scared of kind of coming back into contact with them. And this really affected them. But as we're seeing that that's shifting a little bit as workplace places more emphasis on kind of reintegrating them. And we've seen some in lovely work at Tara and some of the other hospitals where they actually have a welcoming committee, and they do wonderful things for people who have, or workers who've had COVID and come back. Okay, so it's forced us to be creative in our workplaces. And then from a personal perspective, younger single females with children, and I mean, that speaks for itself. If you're doing this on your own and you have to really see to everything at home, it does become a challenge. When healthcare workers have family members who are infected, so they're taking care of their family members and they also have to take care of patients, it really becomes a challenge. And we see for the first time, not for the first time, but basically lots of healthcare workers are financially constrained at the moment because people who do procedures can't do them anymore, and it's affecting household incomes. And financially, that stress is also there for healthcare workers. people who have existing health and mental conditions. So we as healthcare workers, we have our own issues, we have our own anxieties, we are not excluded from the rest of the world. And we find that if we do have depression or anxiety, it's just exacerbated right now. And anyone with a history of substance abuse as well, you know, we tend to kind of, or we might under these circumstances, revert back to that. So whether we smoke, whether we drink, whether we kind of use other substances to get through things, it does put us at risk. And generally, individuals with a lack of confidence or low self-esteem, you might find that they also struggle in these spaces where they feel out of control in some way. Okay. So from current research that's been out there regarding the COVID pandemic, there was a study done by the end of January in Wuhan with hospital workers, which were both nurses and doctors. And they found that 50.4% were suffering from depression, 44.6% anxiety, 34% insomnia, and 71.5% just significant distress. Okay, so we already had seen that in January. And another study that was done in New York, it was a preliminary study that looked at healthcare workers in a tertiary institute. And this was in April. So this was at the time where they started to see a huge number of infections. And the death rate was at about 13,000. And what stands out for me, they looked at attendant physicians, your residents and fellows, and then your nurses. And what's significant is that if you look at the acute stress disorder, depression and anxiety amongst nurses, it's really, really high. But the other samples were also, there were quite high levels of depression and acute stress, as we can see there. So the common factors in all this research is that females are likely to experience mental health difficulties. Nurses are affected more than doctors, but it doesn't mean that doctors are not affected. Younger, less experienced healthcare workers definitely are more at risk. So healthcare workers on the front line will experience also more significant amounts of distress when a colleague is unwell, hospitalized, passes away, or quarantined. So I think, you know, a lot of us have been seeing this list of hospital doctors that's doing its round, that shows us that who has passed away and how many have passed away. And when we look at those kind of things, it really overwhelms us just by looking at it. So those who experience their colleagues in their workspace getting sick and unwell, the kind of feeling it leaves us with cannot be minimized. Okay, so healthcare workers are more prone to depression when exposed directly to the virus or when they infected themselves. So we do know that the COVID-19 will basically has different phases. You had the preparation phase, the early phase, there's a mid-phase, peak phase, tail-off phase, and there's going to be a post-COVID phase. So within that space, we're going to have different sort of emotional responses. Yes, we're all different, but there are some trends, and chances are we will see certain sort of trends in within ourselves and amongst our colleagues as well in terms of mental health. So the early phase, I mean, we all can, if we all look back and think about it, it really was that preparation phase where there was a small number of positives. We started to become more vigilant, and we started to focus on what resources are out there. That was when we were in lockdown, severe lockdown. And there were some ethical dilemmas around hospital beds, how do we prepare for this, and so forth. And the emotional aspects to that, there was this anxiety and there was this buildup. And for some of us, there was this denial, it's not going to be so bad. Oh, we'll be okay. You know, and that's normal when we experience some acute stress, that sometimes, you know, it's almost like this is like a dream. You know, it's going to pass. It's not really happening. And during that time, we saw information overload, and there was also at some points lack of information regarding the disease, and and not knowing how to deal with it. So we are somewhere here in the mid phase and the peak phase. And what I call this phase is almost like the heroic phase, you know, where after that preparation, there was that almost a surge of energy and adrenaline and overdrive. People were setting up groups and wanting to get out there and do things. But it was marked by distress and worry. And as time went by, and from the kind of work I'm doing and the kind of people I'm seeing in my practice and the debriefing groups, you can see people are depleted. They've accessed their reserves, and the caseloads are high. They don't have enough capacity. We're seeing that within the hospital settings, some of the structures are collapsing where there hasn't been enough protocols put in place. People have to make ethical decisions at the moment, and it's overwhelming. And it really is kind of going into that phase where people are feeling really overwhelmed and depleted. And we now start to see some burnout and compassion fatigue as we continue through this peak phase. I know people are saying the numbers are coming down, but we're still kind of in between these phases as well. Eventually, we hope we can reach this point, but we don't know how long that's going to take. So the tail of phase, we're likely to see people running on empty. We're likely to see some burnout and something called retrospective guilt. So now when we're starting to have some opportunity to ease up, you'll find that people start to process and start to think about cases and patients and ask themselves, what could I have done? Should I have gotten some more support? What more could I do? And you start to think of cases and flashbacks about individuals and traumatic situations, and the emotions just start to surface. And eventually, when we see the post-COVID phase, there is they're calling from a psychological perspective, the post-COVID phase is called the second wave in some way, where we're expecting to see the mental health issues starting to surface. So there's going to be this delayed psychological response, and we might see, you know, all these, now when people slow down a little bit, they're going to have the opportunity to process what's happened, and feelings and emotions and whatever they hadn't allowed themselves to look at will start to surface. And it's almost kind of, you know, and I see this with my patients or my clients when they come in and they say to me, I've got nothing to worry about now, but I feel so overwhelmed. Or there's no issues in my life right now, and why am I feeling so depressed? So I think it's that delayed response, because now we function on adrenaline and our cortisol hormones and our systems are on overdrive, and we don't have the opportunity to slow down. Okay, so now that we're in the storm, I'd really like to ask you, what do we do? How do we anchor? What are the tools that we can use to anchor? And I think this is so important. And I'd really like for you to take a moment and ask yourself, you're all adults, and at some point in your life, you must have experienced some sort of distress, some sort of challenge, some sort of, maybe not trauma, but acute stress that had forced you to dig for resources within yourself. And I want you to ask yourself, what was it that got you through your difficult time? What were the 1 or 2 or 3 things emotionally, physically, psychologically, socially that perhaps had got you through the difficult time? And I think it's one thing trying to learn new techniques, but we're also in the midst of all of this. So the first point is to actually go back to what you know and what you possibly have already as a resource and what you can control right now. Okay. So we need to understand stress and stress resilience in some way. And, you know, the previous speaker had described that stress is a normal part of everyday life. We can't avoid it. It actually helps us to get off our laurels and actually go and work and do things. Otherwise, we'll all be couch potatoes watching Netflix. So it gives us purpose and it helps us to do things. So within the COVID context, stress may be really useful because it triggers the sympathetic nervous system within our bodies. And this allows us to function on a bit of adrenaline during emergency responses, especially during the mid and the peak phase of the pandemic. But when it becomes unhealthy is when there's prolonged periods of stress, and it results in dysregulation and starts to impact on our well-being and our health. Remember, the mind and the body is connected, and you can suppress your emotions and think that, oh, my body will continue. Yes, it will. But we often become these volcanoes that are ready to erupt, and it comes out at the time that we least expect it. Okay, so it becomes imperative to develop an internal thermometer that assesses our levels of stress regularly. So you need to be the observer of your stress levels. Nobody's going to do that for you. But if you go to therapy, your therapist will help you to do that. But during this time, develop that internal thermometer. Just take a moment, ask yourself, how am I doing today? How am I feeling today? What can I do to counteract that? Okay, so resilience is a very fancy word that really refers to our body's ability to bounce back after a stressful situation. So when you think of an elastic band and we stretch it, that ability to let go and bounce back is really what we're looking to have and to invest in. When I think of resilience, I think of it as a bank account or an investment, and it has to be made consciously and consistently to have the return. Okay, and think about it, that if you put in the work, not only do you benefit, but your patients, your family, and the people around you. When we have nothing inside of us, we only give that back to the people around us. So remember that it's an investment with a return. Often I hear people say, I feel so guilty. I don't spend time with my children. So how can I take half an hour and have a coffee and sit in a coffee shop, or take time out and just do my nails or sit in a bath? I often hear people feeling exceptionally guilty for taking time out. But then they're in their space with their family members and they're highly irritable and they're moody, but they're there, but they're not present because they haven't given anything to themselves. So resilience is an investment, and we need to be wary of that. So COVID stress, we know that with COVID, stress is unpredictable, it's uncontrolled, and may be prolonged. And prolonged periods of stress may result in burnout. That's mental and physical and emotional exhaustion. And the brain becomes hyper-aroused. And as a result, we feel challenged and disengaged and overwhelmed. But it's that extreme feeling of overwhelmed that even if I go out and I just do one thing for myself, I just can't seem to bounce back. Okay. And a good indicator of burnout, is compassion fatigue. So I'm sure you've all heard about this concept, and we see that regularly amongst healthcare workers, where it becomes increasingly difficult to show empathy or compassion to others or even your patients. When you think about them, there's this feeling of dread and you think not one more. There's negativity, or you think to yourself, I can't do this anymore. And that feeling of physical and emotional erosion that sits in the system when one is not refueled. So if you're not building on your resilience, compassion fatigue will be the end result. And you'll see that it's marked by poor self-care, overwhelming feelings, anxiety, sleep disturbances, apathy, withdrawal, and you just don't want to do this anymore. You even think about not working as a healthcare professional anymore. Okay. So now when we face the storm, I'd like to share with you the concept that Russ Harris describes, and he uses the acronym of FACE, So face COVID. And the F in face stands for focus on what is in your control. So remember what COVID's done to us. It's really taken us by storm, and we feel out of control in all aspects of our lives, not just in the work front. And when we're in crisis, the fear, the anxiety is inevitable and normal. And it's easy to get stuck in the worrying and the ruminating about things that are not in our control. So, for example, we constantly ask, what will happen in the future? Will I get infected? Will my loved ones get infected? But it's not useful to ruminate. And it makes us feel even more helpless. And these thoughts and feelings affect our behavior. It affects how we engage with our patients. How we engage with others. So what can we control? So we can control what we physically do. Emotionally, yes, these feelings will come up, but what do we do with it is also important. The A is acknowledge your thoughts and feelings. So, you know, as therapists, we believe that, and we know that by acknowledging your thoughts and feelings, you start to make sense of things, you start to process things. And yes, it doesn't feel comfortable, especially if we're not used to it. But think about that bottling up process when we just push this feelings right down. They manifest. They manifest in illnesses. They manifest in burnout. They manifest in stress. Or, you know, I often tell my clients, you know, it's like that Coke can. You know, when you were a kid, when you fill that, you have that Coke can and you shake it and then you open it up, it just spills. And when you don't deal with the feelings, they just get stronger and they just spill all over the place. So the reality is that there's no getting away from your feelings and emotions. So let them come up. Acknowledge them. You're a human being. This is normal. And we will experience emotional storms during this time throughout, okay? But we need to give them space. And some techniques that you can use, so sometimes we have all these thoughts in our head, is just taking your phone and go to your notes section and just type out things. You know, that process of writing down in a journal. You all don't have to have a Dear Diary book, but it might help for some. But just putting down your thoughts, and somehow that process of letting go, taking it away from your head onto a piece of paper, just helps. Just think about when you go to the shop and you have to buy like 5 items, and in your head you're saying these 5 items so you don't forget something. Just by putting it on a piece of paper, you almost let it go. So similarly, just taking your thoughts and feelings and processing it and allowing them to, let them go into some sort of space is really useful. And also you can actually have a worry jar. You know, we do this nice techniques with kids and it's really creative, and sometimes we need it ourselves. So put a worry jar and write your worry for the day and put it in your jar so it goes in there. Okay. The one other thing is becoming more aware of your negative thinking patterns and consciously challenging them. So for example, if you get up in the morning and you're saying to yourself, I'm not going to cope, it's a negative thought. The moment you say that, your feelings are negative. You're already feeling, oh gosh, overwhelmed. And then your behavior is negative. So you drag yourself to work, or you're late, or you don't want to be there and you just want to run away. But if you say something like, today is another day, I have an opportunity to make a difference, even though it is challenging. There's just something about that shifts the thinking process. So maybe you won't drag yourself, and maybe you won't feel as overwhelmed. There might be some anxiety, but it's not at that level. So something like I find lots of healthcare workers saying right now is that I'm not perfect. I'm not doing the best that I can. And the reality is just by saying to yourself, I'm good enough. I'm doing the best that I can under the circumstances. Just reassures one that, you are also human, and that you are doing the best that you can, and nothing about the situation is normal. So don't expect to be normal. Okay. And then it's important that we engage in what we are doing. So, to come back into your body. So connect with your physical body. So when we go through acute stress or we go through high levels of stress, Farzana talked about depersonalization, disconnecting. When the adrenaline's pumping, you know, all these hormones are released. You almost sit here thinking or watching your own body and thinking to yourself, oh my God, I'm watching this movie. Is this really happening? And you need to come back into your body and reconnect with your body, because that's not always healthy for a person. So some of those techniques could just simply be pushing your feet on the floor, standing on grass, grounding. Like I know at work you can't always do that. Just drinking some water, feeling that sensation of the water going down your throat, pressing your fingertips together, or just breathing and stretching. Simple techniques that we forget when we rushing back and forth during the day. And finally, refocusing on your attention on what you're consciously doing. So engage. And sometimes we can't engage. We're in the space, but we really not in our bodies. And what's useful is coming back into your senses. So just focusing on maybe 5 items in the room, or focusing on noticing your body on the chair, or just bringing your attention to the sounds and listening to a few sounds, just helps us to, again, connect. So a lot of us, you know, have heard about breathing. You know, we've all watched these movies where people are hyperventilating and they're breathing in these brown paper bags. And really, the reality is that a useful anchoring tool that during any storm would be breath work. It is the one thing that we have control over, and it is the one thing that we have with us all the time. So you really don't have to go out looking for anything when you're doing breath work. And I really want to mention Dr. Ella Manga. This is some of the work that I've taken from her, what she does, who is an integrative medical practitioner. And she's one of the leading voices in the field of mind-body medicine. And she's founded Breathworks Africa. And she emphasizes that breathing is just not an exchange of air. It's a reflection of our physical, emotional, and spiritual health. So we know that in other, like when we do yoga or when we do meditation, the breathing component is really useful in getting us to connect with ourselves. But she emphasizes that we breathe, we develop a BQ, something called breath intelligence. So not an IQ and not an EQ, but a BQ, where we start to become aware of our breathing patterns and more conscious of our breath. Now, why we need to do that is because when we activate it, or when there's an imminent threat in some way, and you know COVID is the threat to all of us in some way, we begin to feel unsafe, and that activates the sympathetic nervous system. And when it activates the sympathetic nervous system, we begin to breathe very shallowly, or we hyperventilate, and sometimes we don't even do it consciously. But remember, the breath and the body and the brain is all connected. And when we start to breathe heavily, or we don't breathe at all, you start to find that we send messages to the brain that we are stressed. And when we send messages to the brain that we are stressed, the brain says, okay, let's activate all the other systems, which means that we might have our pressure increase, our cortisol hormones are released, our fight-flight response is activated, and we need to regulate our parasympathetic nervous system. And breath work or breathing helps to activate that parasympathetic nervous system. So what I'd like us to do is just to take a few minutes to just connect with our breath. We all have been running on overdrive. We all are overwhelmed in some way or the other. And I want us to just take a minute to breathe in for 4, hold our breath for 6, and breathe out for 8. Simple technique. So if you can just breathe in, hold for 6, and out. Breathe in, hold, and breathe out. Simple technique you can take anywhere. But when you're breathing now, I want you to just take a moment to hold, put your hands on your belly. And we don't want to breathe from our chest. We really want to activate the diaphragm. So deep diaphragmatic breathing, which almost looks like you're filling a balloon in your tummy. So make your tummy expand. So deep breath in, hold, and release. Breathe in, hold, and release. And another breath in, hold, and release. And you might need to do that a few times because we're so activated that it's hard for us to actually reconnect with our breath. There was another technique for calming that she talked about, which was box breathing, where you breathe in for 4, 1, 2, 3, 4, hold for 4, 1, 2, 3, 4, breathe out for 4, 1, 2, 3, 4, hold for 4, 1, 2, 3, 4. So it's breathe in for 4, hold for 4, out for 4, hold for 4. And it's a technique that we need to practice. And you know, we don't only breathe or practice these techniques when we activated. We need to practice it when we are okay, so that when we activate it, it becomes something that our body can consciously do, and it's not uncomfortable. So in the morning, when you get up for your fajr, and after your dua, whatever it is, just do a simple breathing technique. At night, when you go to bed, remember your breath. We also know that intentional yawning stimulates the parasympathetic response and triggers relaxation. So don't forget to yawn, don't forget to smile. And there are other techniques like guided imagery that are a little bit more intense. And there are lots of apps out there that help us to do that without even having to think too much about it. So there are apps like Calm and Headspace, which you can download, and it reminds us to continue breathing and being mindful. So there's a whole hype in psychology around mindfulness, which is a psychological technique that brings one's attention purposefully into the present moment. It prevents one from being in autopilot and consciously being aware of our mind's thinking and patterns of behavior. So useful techniques found within this framework is simply becoming aware of your senses. So get up in the morning, become aware of the sunrise, become aware of the sunset, notice the colors, look at the sky and the birds. When we activate it, we don't do any of that. So consciously bring your awareness to the things around you. Smell the sand, look at the wind, or look at the trees gustling, or become aware of the wind on your face. Smell the smell of coffee. Taste your food. Often we're gobbling. We don't even know what we're eating. We're just putting things down. I need you to start tasting your food and appreciating the flavors. Become aware of the sensations in your body, where you're carrying your stress, even the feelings of rest and calm. So when you do feel rested, when you're getting into bed, notice where you're feeling the rest. Notice where you're feeling the calm. Become aware of your feet on the ground, grounding, using the grass under your feet. And like I said, using tools for such as Calm or Headspace, apps that help you to remind you of your self-care. So yes.
We're running out of time a little bit. Do you have a lot of more slides to go?
No, so I just want to share this one with you. So I just want you
some time for questions as well. So,
how many minutes do we have left, Ishmael?
Maybe about 5 more.
Okay, great.
We're already a little bit over time, but we can take about another 5 and then.
Okay, great. So what I'd like us to do is to just, I'd like you to think about preparing a well-being plan, a personal well-being plan. It doesn't have to be hectic. It doesn't have to be really intense. I just want you to look at the self-care wheel and maybe just look at one micro moment that you'd like to, goal that you'd like to add to this wheel. So a small goal, psychologically, emotionally, spiritually, professionally, physically, and personally. So remember that our spirituality really helps us to make meaning of what's happening during this time. And resilience, people who bounce back often have a sense of spirituality that helps them and therefore develops a sense of resilience. So look at the areas of control that you can have physically. So if you go and exercise, psychologically, if you go for debriefing sessions or you do relaxation, and professionally, if you seat your colleagues or you kind of seat yourself in your professional environment, just one small micro moment that you can actually share, you can micro moment that you can have that will take you a long way. Now remember, we have to develop micro moments because we don't have macro moments right now. We don't have big holidays. We can't travel very far. So the micro moments of influence is what we're looking for in our everyday life, not just when we're in crisis. Okay. And finally, I want you to remember that we are running a marathon. This is not a sprint. And when people run marathons, they refuel to get to the end. And from a runner's perspective or a cycling perspective, there is that runners, a brick wall where we talk about runners hitting a brick wall and they just can't go on. Please protect yourself from hitting a brick wall. There are things that you can do to sustain yourself during this pandemic. Be conscious and ask for help and seek out the help and look after yourself, because we need you to get to the end. You are important in this pandemic. Without you, we are really lost. Okay, so just some resources. The Healthcare Workers Care Network is an organization that actually has a 24-hour helpline. If you are in need for training and support for staff members, they also organize that. Your IMASA helpline, Breathworks Africa, Headspace, and Calm. And I will make my slides available. So if there's anyone that needs it, thank you. Thank you for listening, and thank you for the opportunity. I hope that you've taken away something from this.
Jazakallah, thank you very much, Hanifa. Sorry to stress you out the last 5 minutes.
I've got my breathing. It will help with anxiety.
Okay, so I'm going to open the floor for a few questions. So if anybody's got a few questions, we don't have as much time as the last speaker, but maybe about 5 or 6 minutes of questions. So if people want to, they can pipe up. I'm happy for them to do that. Otherwise, we can take the questions via the chat as we did the last time. So I'll give you a few seconds to compose your thoughts and see if you have any questions for Hanifa. I mean, certainly, Hanifa, as you mentioned, this is a marathon, it's not a sprint. So some of the things that we need to develop are habits which we inculcate into our lifestyle. And obviously, from an Islamic perspective, it includes developing that khushu and connection with Allah subhanahu wa ta'ala through our salah, which can really have a great benefit in relieving your mind from your day-to-day stresses as you turn towards your creator and asking for his guidance and his assistance as well. And then obviously things like zikr, things like self-reflection on a daily basis, which are part of the sunnah, where you, before you sleep and before you retire for the night, you reflect over the aspects of the day. You almost debrief yourself psychologically and work out those areas which you need to improve on. Forgive those who have harmed you, and forgive yourself for the mistakes that you may have made in the day as well. I'm sorry, I'm becoming an amateur psychologist.
I like that. Thank you. Thank you.
So I don't know if there's no. I'll give you a couple of minutes, but it doesn't look like there's many questions. I think you've covered everything. People are so relaxed now; they don't want to think about questions.
A mouth.
So, but we'll give a minute or two. Is there anything else you want to talk about, Hanifa? Okay, I mean, while we got you, just to mention that you mentioned the IMASA helpline, and IMASA is busy trying to compile a directory of counselors and psychologists around the country and in different areas where doctors can refer COVID-19 affected patients and family members, and also where doctors and healthcare workers can try and get assistance themselves. Obviously, some of them are offering that service pro deo, others are offering it at the normal rate, so it's worthwhile just inquiring what people are offering. But we'll try and get that list of counselors and people who are available to see people with affected with or infected with COVID-19. So we'll try and get that list out. Okay, so I think Sharika is on board, so we can maybe then go to our final speaker for this afternoon. Sharika, are you around? Okay, so Jazakallah, thank you very much, Hanifa. I think you've exhausted all the questions, so I don't think anybody else is. We haven't received any questions, so we're going to move on to our final speaker. Our final talk is by Sharika Angamia, who is also a clinical psychologist, and she's going to talk about grief in the context of COVID-19. Sharika is, as I mentioned, she's a psychologist currently in private practice at the Ecology private practice in Indonesia, but she's worked in multiple fields, including Akiso in Soweto, Akiso in Waverley and in Parktown. She has worked and trained at the Chris Hani Berganath Hospital as a community service clinical psychologist, and as well as the Sterkfontein Psychiatric Hospital, and was among the top 15% of graduates from her class. So we welcome Sharika to talk to us about grief in the context of COVID-19. Sharika, I see she left. I don't know whether she's trying to connect again. Zephyr, do you want to just check?
Yeah, I've just checked with Sharika. She's just having some connectivity issues. She will be joining us shortly.
Like several times in the past few minutes, I think she may be having some connection.
Yeah.
I could talk about grief, but you may end up crying at the end of my presentation. So I think we'd rather let Sharika do it. If anybody wants to share their thoughts or their recommendations for future presentations and webinars on the chat, they are welcome to as well, and we will take note of it as well. Sharika, I see you are back. Are you back, Sharika?
Assalamu alaikum, G. I'm back, and
so I introduced you. I'll go through it again. So as I mentioned, Sharika is a clinical psychologist who is, and I mentioned some of the areas where you have worked and where you're currently working, including the Ecology private practice in Indonesia, and that you're among the top graduates from your class in psychology. And we look forward, inshallah, to the insights you have to give us on grief in the context of COVID-19. So you can begin at any time. I think you may need to, I don't know if you have a presentation to share.
I do. This firstly turn my camera on. I'm also having a bit of technical issues. I don't know if everybody can see me clearly. Is it okay?
We can.
Okay, perfect. Okay, Jazakallah. Sorry, I have to move around a little bit because of my Wi-Fi issues, but it looks okay now. So I'm just going to quickly share my presentation. Assalamu alaikum to everyone. Please let me know if everything's clear, if everyone can see the presentation. Okay, can I just get a little bit of feedback from anyone just to let me know if the presentation is on and if you can see me clearly, hear me clearly, and see the presentation?
Yeah, the presentation is visible. I think change a slide and we can see if it changes, and then we're good to go. Yeah, that's fine.
Perfect. Okay.
Okay.
Jazakallah so much for everyone who joined today, and I'm hoping this is going to be, although we're going to be discussing a very difficult topic, I'm hoping it's going to be informative, and I'm hoping it provides benefit in terms of dealing with a very difficult topic. So yeah, an introduction obviously isn't necessary, so I'm just going to jump right into the presentation. I'm going to try my best to ensure
Sharika, it's just Huzaifa here. Some of the delegates are requesting if it could just be a little bit louder, or if you could maybe just move a little bit closer to the mic.
No problem. Let's see, how's that? Is that a bit better?
I think, yeah, that is a bit better, yeah.
Okay. Let me just go back to the presentation. Okay. Yeah, if there's still a sound issue, please do let me know, and I'll just, I think, maybe turn my microphone up. Okay. So as I mentioned, we're going to be discussing a difficult topic, which is obviously grief during COVID-19, which in itself has become, how do I say, a difficult topic to deal with, number one. Number two, I think what's happening is we are faced with, as healthcare workers, as psychologists, as doctors, as nurses, as general healthcare workers, we're faced with a very difficult task. We're taking on a lot more than we're used to taking on because we're sitting in the midst of a global health pandemic. And I'm sure, you know, this has been said now throughout the presentations, and you'll see some of my presentation will overlap with Hanifa's, not much, because my presentation is very much focused on grief. But in terms of just the overview of the presentation, I'll be focusing on the fact that we're experiencing what we call a collective loss. So generally speaking, you know, as a psychologist, I would deal with someone else's grief. I would deal with someone who's lost a spouse or a parent or whoever, and it would be a separate process to me. But it, you know, obviously does affect you emotionally, but it's generally quite a separate process. But what we're going through right now is called a collective loss. We're dealing with the loss of, you know, numerous losses, the loss of life, the loss of incomes, the loss of normality. We're dealing with numerous losses, and it's not just, you know, us in our specific communities. We're dealing with global losses. We're looking at a global health pandemic that's affecting people in various forms, not just social, not just financial, in psychological terms, in emotional terms. We're being impacted in many, many ways. So the process, which was complicated to begin with, has been made even more complicated right now. And the protocols that we would normally put in place, the ways that we would normally deal with this, we have to change. We have to be flexible. We have to look at alternatives in terms of dealing with how we process the grief as healthcare workers, and also how our patients process the grief. So the way in which our patients experience grief and how healthcare workers are now processing grief, you know, they have to basically manage themselves, manage their own process, and manage their patient's process. And the way that they experience grief has obviously been made a lot more difficult because of the various factors which we'll discuss. So I'll also be discussing how maybe in the past, because of the coping mechanisms that people had at home, because of the coping mechanisms that healthcare workers themselves had, an interdisciplinary approach to grief wasn't integral, it wasn't extremely important. And right now it has become extremely important because our resources are sparse. We don't have the coping skills that we would normally have at home. We don't have the coping skills that we would normally have internally. And like I said, some parts of the presentation towards the end might overlap, but with Hanifa's presentation. But overall, our coping mechanisms have been stripped away by COVID-19. What we're doing to process grief, what we're doing to process our losses as healthcare workers, and also what we're doing to process the loss of our patients, or, you know, to help them manage their losses, it's totally different. It's changed in a major way because there are various stresses that we have to take into consideration. So COVID-19 has already, you know, complicated the process, like I keep saying. It's made it more complex, and it's made it more complex for various reasons. In terms of just the definition of complicated grief. So, you know, we discussed the grief process, but it becomes clinically significant when the grief becomes complicated. It becomes a more intense, more prolonged response to loss that affects a person's activities of daily living. And why I say that is, a lot of people tend to get a bit confused with what is loss, what's bereavement, what's grief, what's, how do I know if this is a normal reaction or not? So if you think of the definition of grief, it's when a person experiences a loss, it's the reaction to a loss. So in our as healthcare workers, in our sense, we are reacting to our patients' loss, but we're also reacting to the loss of certain skills that we would put into place, certain resources that we would have. We're mourning a collective kind of resource that we've now lost, that we're not able to use. So what complicated grief basically includes is it speaks about sudden death. So, of course, we are not mentally prepared for the effects of COVID, or we weren't really mentally prepared, because what we had was a virus that nobody really understood, that sort of came out of nowhere. It was very localized at the beginning stage, and then it spread very rapidly in our country. We got to a very difficult part, and this is a feedback I got from a lot of my patients, was we got to witness what happened in Italy. We got to witness what happened in the United States, how people died, in masses, and that was really scary, because we had to cope with sudden death. We had to cope with not a prolonged period of sickness, a very sudden onset, and a lot of people who were relatively healthy got sick very, very quickly. We've had to deal with traumatic death, so witnessing our loved ones die, witnessing masses die overseas. We've witnessed, the loss of loved ones that, we didn't really, nobody can really anticipate grief or anticipate death, but generally speaking, you have some sort of comfort that says, okay, my family is in relatively good health. They're probably going to be around for a little while, but the grief is sudden, it's traumatic. They happen for healthcare workers especially, and also for our patients, but we're experiencing multiple losses. Usually there'd be a time period where you'd be able to process a loss. With healthcare workers, you are processing multiple losses very, very close together. With patients, they're losing family members, they're losing neighbors, they're losing people from work, and it's multiple losses, and they're not getting the chance, or they're not giving themselves the chance to process the loss. And then, like I've been speaking about, the concurrent stresses, the financial stuff that's going on, the lack of coping resources, the global anxiety that we're experiencing because of not knowing enough about this virus. All these types of things are concurrent stresses. The health concern, which is obviously the big one, we're sitting with, okay, so my partner or whoever just recently passed away from COVID, and I'm actually in the COVID, I'm COVID positive, and I'm in the recovery stage. Am I also going to pass away? Am I going to recover? Are my children going to get this? So as I'm speaking, you can hear there's concurrent stresses that our patients are experiencing, and us as healthcare workers we have to process this as well. We don't only have to process the fact that we lost a patient today. We have to process the fact that we've been in contact with so many COVID patients, and now we need to go home to our maybe vulnerable parents or our kids or whatever. So basically, all of this is compounding and making the grief process very, very difficult. Like I mentioned, these are the concurrent stresses. I'm not going to go too much into it again, but a big factor that we're looking at, and that I think has made the grief process very complicated, and what research suggests, is the isolation and the social distancing. Our patients are not adequately prepared emotionally, psychologically, to deal with the fact that they can't, for example, from an Islamic point of view, they can't hustle their loved ones. They can't be there maybe to read the loved one's kalima for them, or whatever the case may be. I'm just speaking from an Islamic perspective, but basically all religions, all kind of cultures are faced with a similar response. We can't have our ceremonies, we can't do the traditions that we would normally do, and these are, although they are necessary from a religious point of view, what they serve for us psychologically is they serve as a coping mechanism. They give us a chance to process. There's a lag between when the person passes away versus, when the visitors stop coming to visit. The visitors are there to assist you, to provide support, things like that. So if that makes sense, what's making the grief process more complicated is all these different things that are taking away our resources and taking away and adding complexity to an already complicated situation. So in terms of the presentation, I'm going to firstly be speaking about caring for the patients. How do you comfort a patient who has not just lost someone? How do you comfort the children? If you do have access to them, which generally you wouldn't, but I mean, what coping skills would you give to the parents to comfort the children? Those types of things. In terms of the presentation, I'm going to be speaking about that first, and then very much, and I think equally important, how do you assist the healthcare worker to cope with grief? How do you know if you're grieving? What do you look out for? How do you know the difference between if you're experiencing grief versus depression versus anxiety? So, in terms of the difficulty that we're having right now, I would say the main difficulty that healthcare workers are experiencing is balancing, what the family wants, what the patient wants, versus what you actually have at your disposal. What can you actually do to assist versus what does the patient want you to do to assist them? What can you actually do? What is within your capabilities to look after yourself versus the amount of time that you have, those types of things. So basically, it's balancing out the needs and wants of your patient versus what the COVID reality is right now. So the difficulty that we're having is the patient wants one thing, the patient is maybe obviously bereaved, or the patient is now, the patient's family is now bereaved and they want access to the body. They want access to come and say goodbye. And this is obviously not allowed for obvious reasons, but we as healthcare providers, or doctors, nurses, whoever is there to assist, can't really do that. They know that they can't do it, but it's the hardest thing to be able to tell a patient, sorry, you actually can't come to the hospital to say goodbye. So we're balancing all these types of things in our minds, and we're balancing what our patients need. So when you're looking at balancing what the patient wants versus what we want, we obviously want to make them comfortable. We want to make them feel that they are heard. We want to make them feel that they're important, that this is not just another COVID death. This is another human being that we've lost. But at the same time, we have complications. For example, your patient wants you to, your patient's family wants you to be able to communicate with the patient, but the patient is on a ventilator. The patient can't talk. So the onus is now upon the healthcare worker to facilitate communication, which is extremely, extremely difficult. This leads to the healthcare worker needing to make decisions, needing to make important decisions on, how do I facilitate communication? Are there other patients? Do I have the time? Do I have the availability to facilitate this communication between patient and family? Is the patient declining too rapidly that I don't actually have the time to assist the family to grieve or to say goodbye? I have, another patient who's now very sick and going to pass away. And if that makes sense, you're basically in this constant conflict with yourself, your patient, and your morals and your values all the time. And I think that's where the difficulty regarding grief comes in. I'm just going to speak, and I'm sure a lot of people who've joined in who have had a similar experience to this, but just to put it into context what I'm saying. I wrote up a quick case study to say basically Mrs. M is a 68-year-old woman who lives with her 70-year-old husband in Cape Town. She's admitted to hospital with severe respiratory issues and is now dying in the COVID-19 ward. Her husband, who is diabetic and very high risk, is unable to contact her. He's not technologically savvy, and he's told that he's not allowed to physically see his wife. He receives updates from the ward nurse on his home telephone, and both individuals now, both the patient and the husband, are experiencing the grief, so their separation and the imminent death of Mrs. M. Added to this, there's no support. The children who would normally be there live in Johannesburg, and they can't get to the grieving patient in time. How does the healthcare team support the couple? How does the healthcare team deal with this heartbreaking situation on their own as well? And so in terms of caring for Mr. and Mrs. M, I think that's where the difficulty comes in with grief. It's not just caring for the patient in their last moments, it's caring for the family. It's making sure that the family is adequately supported, and it's making sure that you are adequately taking care of yourself so that this doesn't lead to a whole host of psychological difficulties that are going to impact the next patient who passes away. So the first thing and the obvious thing is to use technology. Thankfully, we live in an age where video calling is relatively easy. Even making a phone call is relatively easy. assisting a patient to write a note. All these types of things to connect in whatever manner possible is so important during this process in particular. Normally the family would be there to do all these things, but unfortunately the burden is now on the healthcare team to facilitate this grief process or facilitate these goodbyes. A lot of the time the death, it's so also, or rather the decline is so rapid that the family is still hopeful. The family might feel like, okay, my partner or whoever is still going to come home. So they don't do the necessary things to facilitate their goodbyes. They don't say goodbye. They don't reminisce with each other. They don't do the necessary prayers, because they think, okay, by the time this is over, hopefully my partner or parent or whoever is going to come home. So they have that hope, which actually becomes detrimental to the grief process, because they don't do those kind of things to wrap up the process. And that can lead to complicated grief for the patient down the line. Providing reassurance. So this is something that it's crucial. It seems so obvious, but when you're faced with a whole host or ward full of sick patients, it can be so difficult to just say a couple of words of reassurance to the family, just to say, your partner or whoever is really being taken care of. We're doing the best to make them comfortable. We're doing our best to make sure that this person has company, and we're here, and all those types of things. Whether or not it's possible is a different story. So I'm obviously not advocating lying to your patient, but I'm saying try your best to reassure that there are people around that are checking on and on the patient, and the patient is not basically dying alone. Because that's a very, very difficult thing and I think the most common thing that I hear in my practice is my partner or my husband died alone, and that's a very, very painful thing. So allowing the family to verbalize their feelings to you, because sometimes you can feel like you're a bit of an emotional garbage bag for your patients. You are, all the sadness, all the anger, all the confusion is being dumped on you, but it's a part of the grief process, and being able to now process that yourself, and we'll go on to this later, being able to process it for yourself and let those feelings go is also very important for both, because then from your side it also gives you that purpose to say that I have done my best, I've done enough for my patient. So if possible, this is the most important part, or I think a very important part as well, is seeking help in your setting. Mobilizing support, mobilizing your psychologist, if there is a psychologist, or your social worker, to go and check on the elderly man to see if he's coping. Is he eating? Is he doing the things that he needs to do? Is he taking his medication? Or is he so overwhelmed by grief that he's not doing anything? Is the family on the way to see the patient? It sounds really overwhelming, because it's a lot more than you'd normally be doing for your patient. But unfortunately, that's what our context requires. It requires this interdisciplinary approach, this kind of more mobilized approach to grief, which wasn't really necessary, because the patient would go home and have the funeral and have the family to look after them. But that's not here right now. Mobilizing spiritual care is also a very, very important part that I missed out on, because sometimes the spiritual side of it, or more often than not, the spiritual side of it is not really possible. You can't do the rituals and the prayers that you would normally do, because it's just not possible. And being able to facilitate having a mulana go and make a phone call to go and read to a patient, to provide some sort of spiritual guidance, these things are also crucial to helping your patient cope. So I'm also very aware of time, so I'm going to go a little bit faster. Caring for the demise and how to manage the pain. So this is it's also a very, very important part, because once the person has passed away, there's all these sort of feelings that come about, and these feelings that are very different now, because it's not, COVID isn't well understood by the patients. COVID isn't really well understood by anybody, if that makes sense. So people are confused. They don't know what to expect next. So communicating with the family first, to show that you empathize, to show that their feelings are valid. You understand the anger, you understand the sadness that they're going through, you understand the confusion that the family is experiencing now, because the patient died very suddenly. So just validating, not providing psychological support, not providing counseling of any type, just the validation to say, I cannot imagine how hard this must be for you. We wish you could have been here. We wish this could have happened. Just some sort of how do I say, validation goes a long way for a family member. This is something I've heard a lot, is preparing family for the next step. So a lot of people aren't mentally or emotionally prepared for the difference or the different way that a loved one's body is treated during COVID-19. It's very clinical. It's very it's not as personal. The body, the way the body is buried, all those types of things. Family members are not emotionally prepared for this. They don't. It's not even that they don't understand it. It's that they can't process that my loved one is being treated as a infected person. It almost seems that some of the feedback that I got from my patients were, it seems disrespectful. It feels like my loved one wasn't treated with any care. So unfortunately, you can't change protocol, but what you can do is provide that preparation for your patient's family to say, this is the next step, this is what's going to happen, and this is why we're doing this. And this also gives them a sense of control in a very uncontrolled situation. And then reflecting the importance and value of the patient, like I mentioned, this is not just another COVID-19 statistic. This is a human being. This was a father or a mother or a brother or whatever. It goes a long way with our patients. Respecting the family rituals. That's another thing that I think I have spoken a bit about. But, virtual family participation. One of my clients gave me feedback that they were allowed to read their kalima for their mother via telephone. And that made his healing process significantly better, because although he couldn't physically be there, he was part of that kind of, emotional and spiritual saying goodbye that he didn't think he was going to get. And the doctor was kind enough to do that. So those types of things. And also, like I mentioned earlier, thinking out of the box and being flexible right now is so important for the grief process, because what it does is we are in thankfully a situation where we can record voice notes. We can, with the express permission of a patient, take a picture, those types of things, do a handprint, do a written note. And these things go a long way for our patients, because it's a personal touch to an otherwise very impersonal situation. So these are just some examples of how to manage your patient, and also how to kind of make their grieving process a bit easier. I'm just going to play a quick video. I hope it does play. I don't want to go too much over time, so I'm hoping it plays. Please let me know if there's any difficulty.
I think if people have questions in the meanwhile, maybe they could submit them via the chat, and then we can sort of take those questions once we're done.
Okay, perfect. Can I go ahead and play the video?
Please. I'm not sure you're struggling to get it on, Sharika.
Is the audio?
No, we're not. I don't know if anybody else can hear or can see the video. I can't see the video.
Oh, you can't see the video. Okay, I'm not sure what's on.
Is anybody else seeing the video? Are you seeing the video?
No, Sharika, I'm not seeing the video. You might have to stop sharing and then start sharing desktop, include sound, and then we'll be able to see it. So we may have to just stop sharing for the moment.
Okay. And then you said
share desktop.
Okay.
Okay, and then yeah, you can just make it full screen play, and then I'll tell you if you can hear the sound.
Okay. Thank you. What is it?
The video starts playing, but it's paused now on 9 seconds with no sound.
Okay.
Yeah, I think we can't hear it. It's not audible.
Is it, can I just pause? Is it playing? Can everybody hear?
We can't hear it.
Oh dear. Okay. And this is where my technological issues come into play. Anyway, how do I remedy this?
Just when you click on the open share tray, you should have an option that would allow you to include the device audio.
Okay. I don't know if I'm doing the right thing. Okay, so desktop.
And then there should be a tick
include
box.
system audio. Is that it?
Yes. Yes.
Okay. So that should be okay now. Okay, there we go.
Good pulses with CPR. You getting tired at all? Epi's in. That's the 5th dose of Epi since the vasopressin.
He's still in asystole.
How's he bad? He's still right.
Let's stop CPR for a minute. He doesn't have a pulse or audible heartbeat. Is he assisting at all?
No, he's making no respiratory effort.
We've been at this for 30 minutes. Does anyone else have any other suggestions? Let's stop. Let's call the time of death 9:30.
Okay, everybody, can we just take a minute for a pause? This was somebody's father, somebody's husband, somebody's friend. It's part of our mission to know me, care for me, ease my way. Let's take this time to honor the fact of this person being here with us and also how hard we tried to save him. Let's just take 30 seconds and honor him.
Thank you for all your efforts. Has the family arrived yet? We'll get them.
Okay. So, I'm just going to go back to sharing the slides. Yeah, so I hope everybody could hear that and see that. So obviously very, you know, dramatized, that's the right word, I think, because I think that, you know, I've personally never been in this situation, but a lot of healthcare workers, I'm sure, can relate that these situations happen, you try your best and you lose your patient, and it feels like in the context of COVID-19, there's a lot of other people who are going through sickness and who you need to check on, but you don't give yourself that pause, or you might not feel like you're able to honor the patient, because even that 30-second pause can feel like it's too long given our context. But it makes all the difference when you bring yourself to the present moment, not what you have to do next, not what you could have done better, not what more you could have done, not what the next steps are, but rather to the moment and acknowledging what is going on right now, how you're processing it, and also whether or not you know, how do I say, whether or not your pause is 30 seconds or a minute or whatever you do, but pausing and bringing yourself to the present moment makes it a lot easier to wrap up that emotional part of that process, and then moving on to the next patient. But it gives you that sense of, I've honored the patient, I've honored my own feelings, and now I can deal with the next person who needs my help. And it takes 30 seconds. it's not like a very long process. But even though you worked on or tried to help this patient for ages, and really put your all into it, just acknowledging your own efforts and you know, and who the patient was makes all the difference in terms of your grief process. And it's very helpful to let the family know that you've done this for the patient. And now I'm going to go much faster because I'm very aware of the time. But obviously speaking then, and I think what a lot of healthcare professionals are here for is their grief process during COVID-19, because like I mentioned before, you're not just grieving your one patient. There's many patients. There's a lot of effort that's put into trying to manage the patient. There's a lot of unknowns related to the patient's passing away and things like that. So it makes the grief process for a healthcare worker a lot more complicated as well. So this is, you know, when they speak about wounded healers, it's very psychological, but I think this very much applies to what's going on right now. They speak about how wounded healers are people who create meaning and create, or sort of come out and create, even though they have experienced their own wounds, they create meaning from their pain, and they go on to shine light for other people who are going through similar things, and also shine light for their patients who don't have that hope. So wounded healers are basically, in the helping profession, there are people who are now have been traumatized themselves or are grieving themselves and now have to go on to shed light for other people. So like I mentioned, healthcare workers are experiencing more intense emotions, and they're expending more emotional energy because of the COVID-19 grief process. They're dealing with the end of life. They're dealing with the physical suffering of their patients, the emotional distress, their physical suffering, so the healthcare workers' physical suffering, their psychological pain, and it leads to, and I think Hanifa did mention something similar concept, moral injury or moral distress. This I thought was very interesting because of technology, because people have more access to healthcare, or at least a certain portion of the population have more access to healthcare. A lot of people tend to pass away, instead of being at home passing away, they tend to pass away in hospitals. They are passing away in a context where they're more surrounded by healthcare workers than their own families. And this leads to obviously increasing involvement and support for the patients by the healthcare workers. What a lot of healthcare workers report are they don't feel adequately prepared. They don't feel like their training adequately prepared them to deal with a global health pandemic and the resultant effects. The prevailing attitude of a lot of healthcare workers are, we need to soldier on, we need to deal with it. There's a global health pandemic going on. This one loss or this one moment can't define me and can't affect me so deeply. So they tend to push it away and say, let me rather carry on, let me deal with the next factual thing that I can deal with, or kind of concrete thing that I can deal with, as opposed to really coping with my own sense of loss. And another difficulty that they experience is, instead of noticing that they are grieving, they start feeling more stressed, they start feeling more anxiety, they start feeling more depression, and they can feel this in themselves and also misinterpret or misdiagnose this in their patients. So healthcare professionals' losses. So obviously we are facing, because of the global health pandemic, we're facing serious illness. We're facing death more frequently. We're witnessing patients dying alone, which is unusual. We're witnessing our patients dying, you know, or their family members grieving alone, which is unusual. It's not something that we've seen or see often. Where we used to seeing family members in the waiting room, people to go and report to, people crying, people comforting one another, and now it's very bleak, it's very clinical. It's like you know, the whole process has been fractured, and that's unusual. It creates what we call cognitive dissonance, where you are conflicted. Your reality versus what you know or what you understand, your morals, your values are totally in conflict with one another. So what we experience is there's no mental preparation. There's many unknowns related to COVID-19, and the overarching concern that people have for themselves is also an additional stressor. You're worried about the fact that you are going to go home, and now you have to emotionally maybe deal with your partner. You have to emotionally be available for your children, and do you even have the capacity for that? So what this leads to, and I think Hanifa spoke a bit about this, so I'm just going to be aware of time, so I'm not going to go too much into it. But compassion fatigue, your physical and emotional inability to empathize or to nurture others because of continuous self-sacrifice. And then obviously the burnout aspect of it. it's triggered by your workplace demands, having a lot of not enough staff, not enough, taking on longer shifts, all those types of things. And it leads to a sense of cynicism, a sense of, is this ever, like pessimism as well. It leads to all of that because you feel like, is this ever going to get better? Are we ever going to come out of this? Is this ever going to get easier? And you tend to burn out. You stop looking after yourself physically, emotionally, and you lose motivation. What I'm not going to read this too much, but basically moral distress, as Hanifa mentioned, is it's needing, when you need to be in conflict with yourself, when you need to act in a way that opposes your own belief system. It's difficult, it's really, really hard because it creates that feeling of unrest and uncertainty in yourself that you can't really put into words, but you know that this goes against everything that you believe regarding the grief process and regarding supporting your patients. So again, having to witness patients who are dying alone, having to provide care for patients with limited access, limited PPE, etc., the inefficiency of our healthcare system, all those types of things are leading to a sense of moral distress. I know I could be providing more, but I can't because of X, Y, and Z. What needs to be developed is moral resilience, finding meaning in your despair, focusing on, I think Hanifa did mention this, focusing on at least one bright moment or something positive that could have come out of the situation, even though it seems it's an adverse situation that you're in, but being buoyant in these adverse circumstances. So now just to kind of wrap up, I'm just going to speak a bit about how to deal with the compassion fatigue. And these are very practical things that I think people don't realize. I'm not sure if this can be implemented in every setting, but these are small strategies that you can put in place to deal with and to cope with the compassion fatigue, burnout, and moral distress. So one suggestion is to appoint what we call a wellness champion. So someone that is looking after the wellness and well-being of the people in the ward. I'm just going to use the ward, for example. So it might not be, when you're in private practice or whatever, it might not be as easy, but having someone or even a partner who is your wellness champion, who starts off each day, whether it's in the morning, whether it's at the end of the day, starting with a reflection or word of the day or prayer that brings everybody together in spirit and enhances morale. It sounds very silly, or it sounds even just impractical because, we've got stuff to do. We have things to do. We've got patients to see. Taking 5 minutes, taking 2 minutes in the beginning of the day to do a quote of the day, to inspire your colleagues, to inspire the people around you, can help with the sense of compassion fatigue. It's starting off the day or ending off the day with a positive note. And people forget to do things like this. I know because of obviously the healthcare concerns, a lot of people don't eat when they're at work. They're scared to eat at work. They're scared to take off their gloves. They're scared to, touch their faces and things. But, having someone to bring in comfort food when they've had a particularly difficult day. It's small things like this it's self-care, it's building morale in your unit, which is something that people are not doing now. Everyone's very fractured. Everyone's doing their own thing and trying to cope in their own ways. But building that sense of team also helps your whether it's at home or in your ward to boost your morale. What can I do if I'm struggling? Ordinarily, we'd use things like ICAS, we'd use, healthcare counselors. We would ourselves go to therapy, but a lot of therapists now, a lot of psychologists aren't seeing people face to face. But what we need to do is to be flexible, seeking out, having a buddy system, seeking out someone who you trust, maybe someone you studied with or someone that you're working with, who can take on an emotional load, and seeking out or being each other's buddies to debrief at the end of the day, discuss difficult situations, creating emotional WhatsApp support groups with people that you feel comfortable sharing your feelings with. I know this is a tough one, but raising ethical issues such as shortness of staff or trying to limit workload stress by having certain times during the day where you can take a break. It sounds very impractical, but even a 5-minute or 10-minute group meeting to debrief with each other makes all the difference in terms of dealing with your own grief. Speaking to a professional, a lot of people feel like I should have this. I'm the healthcare professional. I should be the one that's healing people. I don't need to be healed. But the opposite is actually true. Healthcare workers are dealing with so much more than they should be dealing with right now, that seeking help and speaking to a professional, joining a Zoom support group, which I think is very readily available right now for healthcare workers. Doing these types of things don't show weakness. It actually helps you to build that resilience and helps you to heal when you've been wounded. The mindfulness, I'm not going to go into this at all because time and Hanifa did discuss a lot of this. But exercise, mindful eating, meditation, prayer groups, all these things are crucial right now in terms of dealing with grief. Grief takes an emotional, physical, mental toll on you. So you need to look after yourself before you look after others. So this is just a final wrapping up. But it's very, and I'm sure a lot of people know this, but we need our healthcare workers. We need our doctors. We need our nurses, our anesthetists. We need all of them right now because that's who's taking care of us during this global health pandemic that we're going through. And it's not selfish to look after yourself. It's not selfish to take an hour out of your day to talk to a psychologist. It isn't. I don't know if it's practical, but it's not selfish. There's no shame in reaching out. And we're all, a lot of everyone, whether it's psychologists, doctors, everybody's at risk of complicated grief and secondary stress because, as I've been discussing, it's a complicated, complex situation. Finally, again, like I discussed, finding meaning in these challenging times is what's going to help both the patient and the healthcare worker cope through something unimaginable. And finally, just a thank you, which I think is always very, very important. And this in itself is I think it sometimes lacks because everything that healthcare workers are doing right now for patients and their families and their communities has to be noticed, and we have to thank you. So thank you very much, everyone. I know I've gone very much over time, so I'm just going to open it up for any questions.
Jazakallah, thanks, Sharika. I don't think we have a lot of time left, but I mean, I think there is time for one or two questions if people want to put some questions on the chat, or if they want to deliver the question personally. I'm happy to do that.
Just having a look at the comments. And I don't see any questions right now.
Yeah.
Okay.
I think that leaves us to thank you, Jazakallah. Thanks a lot, Sharika. I think it was an excellent talk, obviously quite comprehensive, didn't leave much space for questions. And obviously it's a lot of stuff to cover and really very necessary in today's time. We make dua that Allah subhanahu wa ta'ala grants relief to all those who are suffering out there, all those who have difficulties around this very heart-wrenching issue for us as individuals, but also as a community, and that Allah subhanahu wa ta'ala grants the entire community and the entire world relief from this difficult test that we are facing at the moment. So that leaves me once again just to thank you, Sharika, personally again, and then also to thank all the attendees and everybody who took the time out from their Saturday afternoon to attend this program, and we pray inshallah that we'll be able to offer further programs which are of value to our members and to the community. So I think if people have got suggestions for talks and programs which we should have, or changes in the format or differences in the way we should run things, please feel free to send that information through to Kashifa or to any of our officers, and inshallah we'll be able to follow through on that. So we finished on that note, and I'd like to thank all of you once more. Assalamu alaikum wa rahmatullahi wa barakatuh.
Connect to Muslim health professionals in South Africa and the world by joining the Islamic Medical Association of South Africa and play a role in improving the health of the disadvantaged communities.
By becoming a member, you join an organization that gives you an opportunity to meet and network with fellow Muslim health professionals.
Contact Kashifa at 011-837-6717 or visit ima-sa.co.za.
The Islamic Medical Association, IMA, caring for our community.